Posted on August 2, 2019, regarding a woman in Orem, Utah diagnosed with triple-negative breast cancer. She consulted with a famous medical center where they recommended a treatment widely used for breast cancer, but not necessarily the best one for triple-negative. The patient decided to travel to California for a biopsy that identified a completely different treatment to be right for her. Her doctor insisted that she receive Cytoxan plus Adriamycin, followed by Taxol, ACT, yet her laboratory analysis could not have been more negative for that combination. Bravely, she traveled to California to receive 6 cycles of the therapy recommended by the Nagorny Cancer Institute, which provided a complete remission, and she is now alive and free of disease 5 years later. Not surprisingly, she became an advocate for our laboratory-based approach, and her story was featured in USA Today on October 25, 2019. When a 41-year-old mother of 3 who resides in Utah realized that the treatment she was receiving for her own triple-negative breast cancer was not working, she contacted my patient for advice. Having already received 3 cycles of chemotherapy, she could feel her tumor growing. When an MRI confirmed disease progression, the patient became alarmed. This is where the story gets odd. Her medical oncologist, given evidence of disease progression, suggested that this could represent pseudoprogression, a relatively rare phenomenon that occurs when immune therapies induce lymphocyte infiltration that causes cancers to falsely appear to grow. Based on this assumption, he recommended continuing the same treatment. Concerned that her oncologist's explanation might be wrong, she traveled to our office where our breast center conducted a biopsy. We confirmed the patient's worst suspicions, that the treatments she was receiving were not working. With residual disease after 3 cycles of therapy, we felt confident that her treating oncologist would use our recommendations. After all, the combination we recommended is established in the published literature and better tolerated than the one she was currently failing. Instead, the physician put his foot down and said he would not use the recommended treatment. Why would this physician insist upon treatments that did not work when there were treatments that would? The patient and I had a lengthy discussion. I explained that she could not afford to continue the current therapy as she was obviously progressing, as confirmed by the abundance of living cancer cells in our biopsy. No patient with 3 cycles of aggressive chemotherapy under their belt should have gross residual disease in the breast. This is just one of many examples of patients who need to take charge of their own disease. I provided to the patient with several of our published studies establishing the benefit of what we were recommending. Saving this patient's life is the most important mission, and we will proceed with our treatment, regardless of what her physicians say or do.